Alrighty, going into pulmonary atresia, let's talk about it. This is kind of one of, well, I would say it's one of the most severe cyanotic congenital heart defects. There are two more that we're going to go over that are pretty severe as well, but this one kind of is up there with them. So, pulmonary atresia, when we're looking at that pathophys, there is no pulmonary valve, so the blood cannot leave the right ventricle and reach the pulmonary artery. So we talked about that tricuspid atresia. It can't go from the right atrium to the right ventricle. Now the kind of the opposite is happening. It can't go from the right ventricle to the lungs. So makes sense why it's still a cyanotic. Sorry, not a cyanotic. A cyanotic. I just realized it kind of sounded weird. It sounds weird either way. It's cyanotic. Cyanotic defect. Um, so it can't get oxygen. Okay, it's just easier if I say it that way because every single time I say a cyanotic, it sounds like I'm saying acyanotic. I'm sorry. Um, I digress. So, anyways, because that right ventricle cannot eject blood, it becomes hypoplastic. We heard that in the last video. Um, Pulmonary blood flow, again, it becomes ductal dependent. So that PDA has to stay open if we want oxygenation. And again, if there's no mixing through either a PFO or a VSD, then that systemic venous blood can't reach the lungs, which is obviously going to cause that profound cyanosis at birth. Clinically, these infants, again, you'll see them with profound cyanosis immediately after birth because of that absent pulmonary blood flow. We'll see lethargy, tachypnea, poor feeding. You also can hear a single S2, and it will have a murmur that's obviously dependent on whether or not there's a VSD or if there's some sort of um, other opening, like a PFO or sorry, a PDA, just to kind of help, you know, with that mixing. Now, here's the biggest problem. If that PDA closes, you'll see signs of shock, which I mean, think about it. It's not very good. Um, it's a huge medical emergency when we start seeing those signs of shock. They won't be able to breathe. They can't oxygenate. And then chronic hypoxia that they have over time is going to lead to clubbing and polycythemia. Treatment, it is going to begin with prostaglandins just to keep that PDA open. If atrial mixing becomes inadequate, they'll do an atrial septostomy. I can never say that, sorry. If they want surgery, it's all kind of dependent on the anatomy, right? Because we need to make sure that it's feasible, right? That they have some sort of shunting to allow pulmonary blood flow and that single ventricle palliation, which that's going from the glen to the fontan. If that right ventricle is hypoplastic. Other thing is post-op, we're monitoring for oxygenation, changes, arrhythmias, and that patency of the shunt. Nursing care, it's continuous. We have to be vigilant. We're going to assess for feeding intolerance, respiratory efforts, as well as their growth trends. We're going to watch closely for signs of that PDA closure, pre-cath, informed consent, NPO, baseline pulses, and checking for any allergies. Post-cath, we're clustering care, we're watching for arrhythmias, we're checking pulses and for perfusion, we're monitoring any sites for bleeding and hematomas, and we're keeping the leg straight. To our parents, we're going to give them very simple explanations, like they don't have a pulmonary valve, so their blood can't not reach the lungs without some sort of surgical pathway or an open PDA. We're going to teach them to monitor for worsening cyanosis, poor feeding, and increased workup breathing. We're also going to enforce the importance of those stage surgical follow-ups and consistent cardiology visits. And then after the procedures, all because there's three of them, We are avoiding strenuous activity and watching for fever, chest pain, and palpitations. These are the resources. And thank you guys. I will see you in the next one. Bye.